is a vulval intraepithelial neoplasia. This is a pre-malignant condition. This is also one of the frequently asked questions in the examination. So etiology is a precancerous vulval skin condition, which is confirmed by the histology. There are two types. This you should remember these two types and their differences. Okay, the first type is a usual type, and second one is a differentiated type. So usual type is HPV related, and they may ask you about the which specific HPV is responsible for causing this VIN. So it is HPV 16. Okay, HPV 16 is associated with the VIN, and in the differentiated type, it is a non-HPV related. It is associated with LS and LP. What we have just seen, lichen sclerosis and lichen planus can lead to VIN, and that can lead to the squamous cell carcinoma. Okay, so this another type differentiated is a non-HPV related but associated with lichen sclerosis and lichen planus, and there is a higher risk of progression to the squamous cell carcinoma. So VIN is of two types, usual type and differentiated type, out of which differentiated has got a higher risk of developing into the squamous cell carcinoma as compared to the usual type. And usual type is a HPV 16 related. The risk of progression to the squamous cell carcinoma is much greater with differentiated type of VIN and needs specialized management. VIN is a commoner in immunocompromised women, and smoking is also a risk factor. So these are the risk factors. They may give in the history that the patient is such and such, and some vulval lesion will be there, and then you need to select the appropriate answer. Okay, the clinical features here, you will get a lumps, burning, itch, irritation, pain, and asymptomatic. What we have seen with lichen sclerosis and lichen planus, if you see atypical features such as lumps or is there burning, then you go for biopsy, because we are suspecting the squamous cell carcinoma, development of squamous cell carcinoma, or behind in these in the background of LS and LP. Okay, so here you have a clinical feature such as lumps, burning, itching, irritation, pain. Rarely it will be asymptomatic. Okay, signs, variable appearance. Generally, it is a raised white erythematous, pigmented, warty, moist, or eroded lesions. And most important is a multifocal lesion. Okay, multifocal lesion are common. Complications, it can progress to squamous cell carcinoma. The range is around 10 to 20. So 9 to 18% there is a chance of development of the malignancy. Recurrence is common. Psychosexual impact can happen, especially post-surgery. Okay, so there is a this VIN itself is a pre-malignant condition. Lichen sclerosis, lichen planus are also pre-malignant, but they are chronic inflammatory disorder. So you can have from chronic inflammation to VIN, and from VIN to squamous cell carcinoma. But from VIN to squamous cell carcinoma, the 9 to 18% chance of or the risk of development of the squamous cell carcinoma. While here it is 2.6 to 6.6 in lichen sclerosis, lichen planus, and lichen sclerosis. Okay. Now, what is the difference? We have seen a few differences between the classical, usual, also called as classical, and the differentiated. Okay, differentiated is on the background of lichen sclerosis and lichen planus, while this usual or classical is due to the HPV. Okay, it has got a VIN2 and VIN3 also. Okay, there is a strong association with high risk HPV type 16. Usually it is seen in a young women of third and fourth, while here differentiated will be seen in older postmenopausal women. Background, it is often associated with other HPV related lesions like CIN, condyloma, etc. And it is related to the HPV oncogene activity. This also you should remember. If you have a usual or the classical VIN, it is a P16 positive and P53 is negative. Here you have a P16 positive and P53 is a wild type. Okay, it's not a strong positive P53. P16 is positive. But in differentiated, you have P53 mutation, which is common, and P16 is negative. Okay, so these particular molecular markers also you should remember for classical VIN and differentiated VIN. Differentiated VIN P53. Here it is P16. Okay. Now, histopathological, how you differentiate between the classical and the differentiated? Here you get a full thickness involvement. Okay, so a full thickness atrophy of squamous epithelium, loss of maturation, increased mitosis extending beyond the mid epithelium, and coilocytosis is often present. While if you see in differentiated, that is the one which develops on the lichen sclerosis and lichen planus, you have mainly the basal layer atypia with premature keratinization and abnormal maturation of the upper layers. Here it is a full thickness involvement. Okay, coilocytosis is frequently present. Generally, it is absent here. Okay, this one is multifocal, warty, basaloid, or mixed lesions and may be pigmented. While this differentiated one is a generally unifocal, flat, thickened, or scaly white plaques. Okay, and this is multifocal. Okay, the risk of progression is lower than the differentiated variety, but significant if untreated. Here, there is a higher risk of progression to invasive keratinizing squamous cell carcinoma. This immunohistochemistry we have seen, P16 is diffuse, positive, strong positive, and P53 is a wild type of pattern. Okay, here P16 is positive, while here it is P16 is negative, and P53 is strongly positive or overexpressed. Okay, and clinical importance, precursor of HPV related squamous cell carcinoma, where it is a precursor of HPV independent keratinizing squamous cell carcinoma. Now, what is the diagnosis? The diagnosis will be on the biopsy. Biopsy will show disorganized squamous epithelium with cytological atypia, differentiated or undifferentiated. Multiple biopsies are required because lesion may be multifocal also, and you should not miss any invasive disease. So, multiple biopsies are required. Then further investigations, ensure that cervical cytology is up to date, because if it is HPV related, there may be associated changes. So you have to do the colposcopy for VIN, CIN exclusion. Then anoscopy is required. Treatment is a standard treatment, is a surgical treatment here. Okay, so first time in the benign conditions or the pre-malignant conditions, the surgical treatment we have seen in the vulva, it is a local excision. Okay, local excision is preferred for small, well circumscribed lesion. It has got a lowest recurrence. Okay, vulvectomy is also there, but it is effective, but it affects the function, and cosmesis is an issue. Recurrence can happen. Alternative or adjunct therapies, but they are not preferred. Local destruction with CO2, laser, cryo, photodynamic therapy can be done. Okay, it is good for cosmesis, but it has got a higher recurrence. Supervision, that is no treatment, but keep under surveillance, especially partial thickness VIN may regress spontaneously, but there is a risk of progression. So this is also not a very preferred treatment. Imiquimod mode, 5% cream and 5 fluorouracil cream, but they are unlicensed, variable results, and not used in the pregnancy. So the treatment is a local excision for the VIN. Okay, so that is what is the standard treatment. Sometimes they can ask you about the treatment also. Okay, then outward referral, always multidisciplinary vulval clinic assessment and follow-up close monitoring is mandatory. VIN 3, there is a significant risk of progression around 6.5%. Follow-up duration, you have to follow up these patients for 5 years after the resolution. So even if the condition is resolution is there, then also you have to follow up these patients, and follow-up of cases up to 5 years is a auditable standard. So that finishes the topic of VIN also. Thank you.